Welcome to the next session in our Elderhood series. We have an illustrious panel with us today, and the way in which we'll organize it is to ask Reverend Tim Dean is here on this end, and he's going to introduce the panel, but then each one will introduce themselves, and Deb Traunstein will give an overview of palliative care and hospice, and then each of the panel members will talk about their role in the process. And some of you know that I just sent to the email list an article called Overruling My Father, and it led to some questions that I'm going to insert at some point, perhaps. And many of you also may have some questions, and I would suggest I've gotten permission from Deb that it's okay to insert a question if you can't wait, but they will have a discussion session at the end also, so don't feel like you have to wait, don't feel like you have to insert your questions, but they're comfortable with having questions during the process. I'm going to pass around an attendance sheet just to keep track of making sure that we acknowledge all of you. We really appreciate coming out at 9 o'clock in the morning on a Sunday, no less. And so welcome. Reverend Dean, you want to start it off?
Thanks, Bob, very much. And thanks for welcoming us to be here. I took part in the very first session of your Elder series, and I was so blessed to take part in that and just to listen in. And I noticed there was a big blank and a TBA next to the hospice and palliative care discussion. And so I contacted the organizers of these meetings and said, I wonder if we might be able to help in that way. And they graciously, kind of sight unseen, took me up on the offer. So a lot of trust has been given and received, a lot of trust. And we're grateful for your partnership and what you're doing in the community. We think this is such an important thing. We're giving our lives to it and our professional lives. And such important conversations to be had. So my name's Tim. I'm one of the chaplains at Keegan Medical Center. I'm not going to introduce everybody. I'm going to let us do that. But just wanted to say one brief word, which is, we've got different and distinct roles, but in the world of palliative care and particularly Hospicare and end-of-life work, sometimes those roles, those distinctions get a little blurred. And so there are sometimes blurry lines between who's doing which job. But my job is chaplain.
I'm Suzanne Anderson, and I'm the medical director at Hospicare. And as Tim said, blurry boundaries, we really work as a team, and we often fill in for each other when people aren't available. Our biggest team effort really is a weekly meeting that we have called the Interdisciplinary Group Meeting, where we discuss every single patient that we have on hospice services, and we have input from social workers, doctors, nurses, chaplains, anybody who's involved with the patient to help coordinate their care and decide what's best for them. It's really a privilege to work there.
Thanks. I'm Deb Traunstein. I'm a medical social worker, and I have a couple roles at the hospital. I'm both the oncology social worker in the outpatient clinic there, and I also work on the palliative team and coordinate the program. And even though Dr. Anderson said we share roles, I would never pretend to be a physician. But Tim is right. Sometimes it's blurry. The whole emphasis, and I'll speak to this after we're done introducing ourselves, is on the multidisciplinary team, whether you're talking about hospice or palliative care. There are many, many similarities to both of those aspects of medicine, but a few differences also. So I'll be speaking about those shortly.
My name is David Kraskow. I'm a bedside nurse on the 4th floor at Keegan Medical Center. I became a nurse about 16 years ago in the year that I turned 40. So I came at it already with some life experience. Our floor has everything from acute care for people who have stroke or chest pain through oncology and palliative care and hospice. So the nurses have to have quite a range of expertise. And I look forward to sharing some of our experiences with you today.
I'm Jane Shantz. I'm a nurse practitioner, and I work for Hospicare, but I spend most of my time at the hospital doing palliative care. And so I'm going to talk a little bit about what we do in a consultation and where palliative care is locally and where I hope it will go.
Great. So as Bob mentioned, if you have a burning question, feel free to just jump right in. We're here today to really have a big conversation as if this was your living room. So, but we will have plenty of time at the end. I do know that it sounded like we had till about 10 o'clock or so to present, and I know some of you might have to leave earlier for other responsibilities, but we'll be here right up until, Bob, is it till 10:30 when worship begins, or a little bit before?
Right,
That-
right.
Yeah, okay.
There's no closing time. If people still want to stay here, that's okay. This room is free.
Your pastor might not like it if you're all up here, though.
We're between pastors.
Oh, you are? Okay, all right.
And the speaker is over there.
Oh,
okay,
there.
good.
Good, all right. So probably many of you, or most of you, have a deeper understanding of what hospice care or hospice services are. Hospice kind of came here first, even though the way I envision palliative care in general, which I see it as a big umbrella of palliative care, at which one end is exquisite palliative care, and that's what we refer to as hospice services or the hospice benefit, which is something that Medicare does extremely well.
Can you explain the word palliative?
Yes. Palliative, actually, I think the Latin word, it stems from to cloak, or palliare, I believe is correct, in press. And if we're palliating anything, we're helping to make, we're focusing on comfort and symptom management, symptom control, and not necessarily curing something. So palliative care has to do with focusing on a person's physical or emotional distress and what we might be able to do to help alleviate that, palliate that.
I just wanted to add to what Deb said that, medical care has come a long way, and it's often very invasive, and it often causes a lot of discomfort because we put people through chemotherapy, radiation, surgeries that actually can cause a lot of pain. And the reason that palliative care is growing is because people are starting to realize that actually the quality of life sometimes has to be honored as much as the quantity of life. And so palliation is really just oriented towards symptom management and comfort at any stage of life. I mean, we often do palliative care for very young and healthy people who have uncontrollable symptoms. But when that care is oriented towards people at the end of life, then it becomes hospice care.
Yeah. So here in our community, we've had hospice services for over 30 years now. Palliative care services have been a piece of it, but I think for quite a lengthy period of time, people thought of palliative care as just like pre-hospice in a way. And I know you've probably seen in the media, particularly in the last year or two, there are all kinds of articles and real-life stories and much more information these days about what palliative care is. And it's actually a type of medicine that really focuses on symptom management, as Suzanne said, not just physical symptoms, but emotional or psychological distress and symptoms along those lines. We as a team focus on not just symptom management, but also trying to find out what a person's true wishes are, whether they're in the midst of a very serious illness that's not necessarily a terminal illness, but just, often a lot of complicated things, maybe multiple illnesses that are really wreaking havoc with their lives. And so a lot of what we do is really help people come to some kind of conclusion about the direction they'd like to go with their care, whether they want to continue seeking curative measures or not. We do a lot of family meetings. There's a lot of attention to advance directives and just helping people really get some good decisions made about what they would like going forward. So a lot of it has to do with rather nebulous things like quality of life, goals of care, patient satisfaction, things like that are sometimes difficult to define very distinctly and also difficult to measure sometimes. So in this era of healthcare, there's a lot of emphasis on cost savings and the length of stay of someone in the hospital and readmission rates and things like that. And we can certainly help in a big way with a lot of those factors that hospitals and other healthcare agencies are really concerned about today. But I think, as Tim mentioned at the beginning too, the main takeaway point about palliative care and also about hospice services is that it is a team approach. I feel very confident within our team and even within the hospital setting that I can go up to a physician and make some recommendations or really feel almost on equal terms with someone, because we have an expertise in our area of medicine that not all other people working in healthcare have. At the root of it, every healthcare practitioner should have a good base of knowledge about palliative care, because really what it is good medicine. And I think of it as kind of old-fashioned medicine, where you're starting with where the patient is, branching out to the family or loved ones, branching out to the community, maybe to an employer. Kind of this concentric circle idea, where you're really just starting where the patient is at, rather than starting first with the bigger circle of what we can do to or for that patient. So it's really a different way of thinking about medicine and healthcare, which to me it's kind of a throwback to the way it used to be 50, 60 plus years ago. I don't know if you want to jump in anything about hospice in particular.
Can I just say a little?
Sure. Why don't we let Jane talk?
I just want to say, a lot of people think that palliative care is just a euphemism for hospice, so they don't have to use the word hospice. It's really true, but that's one of the myths out there. Well, isn't palliative care just hospice? And I think the second, it's not a misunderstanding, but it's a disproportionate way that people try to understand palliative care, is that it's for pain control. And the truth is, we do a lot more than pain control. We really try to take a holistic view of the patient and the family. So for us, the patient is the patient and their family, whoever they identify that to be. And that we work with all of them, because we know that serious illness impacts all of them. And we forgot to mention spiritual distress, so that's the other thing that we address. And we do work really closely as a team. We actually huddle every day to talk about the patients we have that day. And we really keep each other informed on what each of us has done. And the other thing about palliative care is that I think is partly why it's like old-fashioned medicine, and is that we take a lot of time with patients. We basically take as much time as we need, which is a luxury in medicine now because it's so driven by insurance and reimbursement. And so we very commonly will spend an hour and a half, 2 hours with a patient or family, and like the hospitalists just don't have time to do that.
And the busy bedside nurses.
That's right, the nurses don't either. And so as a result, we don't really get reimbursed for the time we spend, and palliative care, it has to be subsidized because so far insurance doesn't reimburse. They reimburse a little, but nowhere near what it actually costs. And they only reimburse the medical providers. They don't reimburse the social workers or the chaplains. They can't bill for their visits. So it's a unique part of medicine for that reason too.
That's true. And one of the reasons that we're so fortunate to live in this community is because we have Hospicare, which is unbelievably well supported by the citizens of Ithaca. We have as you've all probably heard about Women Swimmin', which is this amazing fundraiser that brings in a lot of money that basically subsidizes a lot of the care that we give to people where insurance companies and the individual can't foot the bill. And I think of palliative care as a large umbrella, as Deb described it. What Jane mostly does in the hospital is consultations. If somebody's in the hospital and is either seriously ill or has symptoms that aren't able to be controlled, the hospitalists or attending doctors will often ask Jane to come and do a palliative consult. So often it's just a one-time visit where Jane will say, well, this is what you need to prescribe for this problem, and for this other problem we would suggest, ongoing therapy in this field or whatever. But there's also ongoing palliative care, and one of the things that we're trying to do right now is establish more of an outpatient palliative care program that would be ongoing, continuing support for people who need palliative care. And those are people who usually are facing life-threatening illness. It hasn't really gotten off the ground yet. We're just kind of forming this idea. We do have something that's sort of a nascent palliative care program called PATH, which has been started, 2 years ago at Hospicare? But so far, that's really mostly just phone contacts and follow-up with people who have serious illness and helping them find the resources in the community that they need. We'd like to sort of expand that into a program where we actually give people home visits on a continuing basis to deal with their illness. And that will often lead into hospice as the person gets older and more debilitated.
One thing I just wanted to mention too before I forget is we've probably confused you. I mean, hospice and palliative care both are very, very similar. One key difference has to do specifically with where the patient is. If there is a patient with a life expectancy of 6 months or less, they can be considered for hospice services. Palliative care services, as I think you might have mentioned, can be provided to anyone who has some kind of complicating illness, some kind of complicating situation that they really need assistance with in a team approach with the time that Jane mentioned. So that's a key difference to keep in mind. Many of our palliative patients are found to be eligible for hospice. And in the midst of our work with them, we can shift gears, and I do make many, many referrals to Hospicare and other area hospices in other counties. But that's just a key difference. Yes?
I'd like to ask, can anyone afford Hospicare, or is that just for the wealthy? I'm serious.
No, Hospicare actually has a commitment to providing care to anybody who needs it. It's sort of like income blind admission to hospice. I mean, first of all, I think it's useful to know that Medicare, which insures most Americans in this country, has a Medicare hospice benefit where people can actually exchange their traditional Medicare insurance for the Medicare hospice insurance. And what that covers is everything that a person who wants to die at home would need. Or who wants to die in the hospice residence or whatever, in terms of services.
Well, not quite.
Well, not everything. I shouldn't say everything, yeah, because we do encounter people who think that by signing on to hospice, they're going to have 24-hour-a-day care at home, and that's obviously prohibitive. But
sure, and Suzanne, I'm thinking Hospicare is for the people who are in the residence, but that's not the case.
Oh, no.
You can be at home, you can be...
most of our patients are at home.
Because I'm just learning about this.
Yeah.
Well,
No, the vast majority of our hospice patients are at home. And in fact, if you poll Americans, and I think this is an important point to make, 85% of Americans want to die at home. Currently, about 25% of Americans die at home. So there's a big gap there of people who are dying in the hospital and they don't want to be there. And they don't want to be on life support and all of the other interventions that they are exposed to in the hospital. So most of our patients are at home. We have a 6-bed hospice residence. It actually costs less to stay in the hospice residence than it costs to be in a nursing home. And the care is much superior. You know, we have 24-hour-a-day nursing care there. And
then you would have to wait to be able to get a bed.
Right.
Or you won't get a bed,
Or
or
you
you might
won't
not.
get
You
one.
may not.
You
I
might
mean,
not.
we tend to be full, but we also tend to pick people for the residents who are not going to be there for 6 months, but who are really in crisis and really at the end of their life. And so we have a pretty quick turnover, and we often do have open beds.
And in Tompkins County, right now, we have roughly 40 people on hospice at any given time.
I think
40,
it's more like 50.
45,
Yeah.
closer to 50?
Yeah, it's been 50
50
lately.
That includes Cortland, though.
No,
Oh, really? Okay. Anyway, so
It
the
goes
rest
up
of those
and down.
people are in their homes or in nursing homes. So,
And then if they're
Or
in
adult
their
care
homes,
homes.
what kind of care are they getting, aside from consults?
What they get is their own personal hospice nurse who's assigned to them and will see them on a regular basis and basically functions as a home visit care provider as well as a liaison with the rest of the medical care system. So the hospice nurse, I mean, they really sort of are the crux of the caregiving component, and they will call the patient's doctor for new prescriptions or whatever. They also get a social worker assigned to them. They have access to a huge team of volunteers, massage therapists, music therapy, spiritual care in one form or another.
And an aide for about an hour a day
A home health aide.
is another part.
Can they have 24-hour aid if they need it? Years and years ago, that's how I kind of started out in healthcare. I was an aide, home health aide for hospice.
Well, the insurance unfortunately wouldn't cover
Doesn't
that,
cover.
so people do often supplement by either hiring private aides through some of our local home care agencies, or piecing together what they can. Many of you might have heard of a share the care kind of idea, where you have friends, family, loved
Okay,
ones.
but it's not through you.
But this is through
This Medicare hospice benefit that I was talking about basically guarantees payment for 1 hour of a home health aide a day. You know, and that may be enough to get the person out of bed, get them showered, get them fed for one meal, and get other meals prepared for them to eat later. You know, that's what a typical home health aide visit would be about. But in terms of actually sitting with the patient 24 hours or taking care of all of their needs, that's not something we can do.
Yes, my question is, can one qualify for and receive hospice care at home and still be able to receive every intervention possible?
No. I mean, hospice care is that portion of palliative care where people have decided that they no longer want to pursue curative treatment.
This is an immediate situation. This might happen tomorrow to my brother, who's currently in hospital with a myriad of serious things. And his pulmonologist, and he has excellent health insurance, he's used up rehab services. He has to be out of hospital or out of rehab for 60 days, and then he can start it again. But that's probably not going to happen. So his pulmonologist said, well, you can receive hospice care at home. And my brother has absolutely no intention of dying anytime soon.
Unfortunately, he may not have a choice about that.
He may not have a choice, but
He's still in the frame of mind of
He wants
being
to pursue
fed.
everything.
he lives in a different planet than many of us here do, and hasn't had the blessings of self-growth and awareness and all of that good stuff. He's not there. So are you saying if he goes home and receives hospice care, he's going to have to sign off on?
Yeah. I mean,
Is that New York State law or?
it's part of the hospice benefit. I mean, the hospice Medicare benefit will not pay for people to go to the emergency room and get resuscitated and get put on a ventilator, etc. If people go to the hospital and receive those acute interventions, they have to sign off of the hospice benefit and get onto regular Medicare again, which would cover those things.
Because again, the whole philosophy, the shift that goes on within your heart and your mind about this is that you're shifting away from multiple interventions, curative treatments,
I understand that.
many visits. So if your brother, I don't know if he's in our hospital or wherever
No,
he might
he's in
be,
Nassau County.
he could certainly, you could ask for a palliative consult for him in the hospital, and they could maybe begin to have that discussion.
You think that would be with the hospital
think
social worker? most
You could
likely?
ask, yeah.
Or someone like Jane.
Yeah.
I mean, this would be a perfect person for Jane to see,
Yeah.
because this is where she spends her hour and a half talking to a person about
What their goals are.
how they perceive their situation in life right now, how they perceive their health, how they would like to see the future unfold for them, and how they want to spend the time that they have left.
That would be good. I've tried to, I've tried.
Sure.
to
You might be
introduce
too
this.
close
He won't
to
go
it.
anywhere near it.
Yeah.
But somebody else, a stranger, a professional,
Yeah.
you know.
Right.
The neutral third party,
Jane, will you go to
daily
Long
I say
Island?
that.
Most hospitals do have palliative
Yeah.
care teams now. I
Yeah.
think it's something like 70,
Like about 80%. Yeah,
80%.
and I love your questions. I just want to make sure we get to
Yep.
tell a little bit about each of what we do. But yes, I wanted to mention that Cayuga Medical Center has had a palliative program in the hospital for about 9 years now, in total collaboration with Hospicare, of course.
Yeah.
And, that's exactly the kind of situation that we see each day. And palliative care isn't everywhere. I know Cortland Hospital is now working very actively on trying to establish a palliative program, thanks to the fact that Hospicare is now serving Cortland County.
Cool.
Many small hospitals don't have one yet, but I think it is at least about 3/4 of hospitals
most large
across the country.
hospitals
Did
should
you
have
say
one.
one can sign off of hospice?
Yes, a person who's eligible for Medicare, right, which is usually people who are 65 years of age
He
or
has
older,
Medicare.
basically can elect to have traditional Medicare or the hospice benefit Medicare. And they can have one or the other, but not both.
And
And
we
you
don't
can't go back and forth.
Yeah, we
You
don't
can.
encourage people to go back and forth.
Yeah, we don't like that when
But
they go
there's
back.
no, it's not an absolute decision. If they say yes to hospice and then they change their mind, they don't need a good reason, they don't need a doctor's sanction, they can just say, nope, I'm done with hospice.
Or if they get better.
Or if they get better.
Yeah.
They get better,
Yeah.
right. Situations change. We're talking
Yeah.
about dynamic flow. I mean,
And-
individual people.
That's right, and I think it's a really important point to make that very few people know. I didn't know this when I started getting interested in hospice, is that people on hospice live longer than people with the same diagnosis who are not on hospice, which is very interesting. And the reason for that is, if you think about someone who's got, say, end-stage emphysema, right? That person actually does better at home with their nurse that they can call 24 hours a day, 7 days a week. Not the same nurse, but they take turns covering each other. And with all of their medications in place and their symptoms really managed well, than if they're constantly going to the emergency room, getting different doctors, different interventions, getting admitted to the hospital, discharged. Those people actually die sooner than if they elect to stay at home and be comfortable, because comfort is a big factor in longevity.
Sure.
You know?
And coming from the social work perspective, I attribute that often to the reduction in stress.
Exactly.
Also, if you finally have made this decision to just shift gears, think about the quality of life, no matter how much time you may have, and you can just relax and not be always on edge thinking, oh, I wonder if I should call my doctor, should I call 911, should I try a new treatment, should I travel to Boston for maybe a clinical trial, like what should I do here? And if you've shifted gears within your soul, your very being, to just enjoy whatever time you have, there is solid research now done by, I think it was UMass or
I think there's a
Mass
couple.
General or something, where there is research now where they've shown at least, 2 to 3 months longer lifespan in people who have elected that. Before I go any further, how about we take just a couple minutes at least so that you can find out specifically what we each do as part of the team. And I don't know if you want to talk about maybe a typical scenario or just kind of...
Well, I think we've just been presented with a typical scenario, which is often we're talking about families. Very complicated dynamics involved within families, within family systems, right? And so I think it's there's a temptation to think that this team or a team like this team on some other county is going to fix a problem that's been entrenched for decades. You point to your sibling who's lived a life without embracing, I think, a lot of acceptance and maturity. And so we often say in our line of work that people do sometimes die the way they live. And we can try our best to lead people to water, but they don't always drink. And so it's not that we're trying to get them to drink the tonic exactly, right? We're not offering hemlock. That's not what this is about. But we are hopefully offering a sense of groundedness and purposeful living, so that as people embrace their dying or their disease, that there is life there too. As a chaplain, I'm all about that kind of work. I'm all about the spiritual frame that people use to guide their lives. For some people, that is really diffuse and disparate, and they don't maybe have much of a mind for that. They haven't lived that kind of life. I ask those questions anyway. Who are you? What are you about? What has been the driver for your life? What gives you meaning and purpose? Sometimes that's religion for some. For some it's not. And we get to explore, well, then what is your de facto religion? What's your way of being in the world? And I like to think that I have one of the most privileged positions in the county, because I'm kind of a public minister and a public counselor, and those lines get blurred all the time. And it's a joy, and it's wicked hard to spend time with people who I see contributing actively to their suffering. And that causes me to burn out, because I see something. I know what's going on, and I know where this is going to go. And I see the suffering that's not necessary. And that's where I find myself stymied. But I think hospice and I think palliative care is all about embracing the truth of the world, and embracing that in a way with as much dignity and as much courage as we can. And I think the best in us, in our spiritual selves, allows us to face the hard stuff. And to face it with as much strength and courage as possible. So as a chaplain, I get to try to play that part and listen. I like to say I like to listen people into freedom, and listen people into fullness, and listen people into hope. And that doesn't mean curing or healing in that way, but it can be something much different, much deeper, as people kind of release and let go so much anxiety, and just be present with who they are. And this business of mortality, living in the body. A couple of things I'd point you to. Poetry, wonderful resources. You have, I think, a saint of the Unitarian Universalist tradition in Mary Oliver, who speaks so beautifully about nature and death and grief. And I would point you to a couple of other resources that I found to be very powerful. Just yesterday I was sanding my boat, and I was listening to a podcast, I can't remember the fellow's name now, I'm sorry to say, On Being, Krista Tippett. Let me just tell you, that's a podcast that will change your life. And as you embrace the breadth of spirit and human, this fellow was talking about his life with ALS.
What was the name again?
On Being. It used to be called Speaking of Faith. And I just can't say enough about that as a weekly practice of mine to kind of help me remember who I am and why I do this work. They don't always talk about death and dying, but it does show up a lot, because that's part of the human experience. That's one of the reasons I'm so grateful that you're doing this series. Elderhood isn't just about dying, right? It's not just about dying, but it's about living with that specter out in front. And so we should let that guide our lives so we can live the way we want to live, with intention. I think the best of our spiritual tradition is all about that. So in terms of what I do, I show up and usually one-on-one just listen to a person and to their loved ones, and help navigate and refer and refer and refer and encourage them to talk about these things. Sometimes it's pretty deep water, and sometimes it's terrifying, and often it's really sad and frustrating. But it's sacred and beautiful work, and I'm grateful to be serving the community and serving the hospital.
Can I just say, I mean, I've had lots of opinions and things to say in response to the questions that were here. And so first of all, as an RN at the bedside, I do a 12-hour shift. We have a group of patients, let's say 4 or 5, 6 patients that we're working with. And as I introduced our floor, we have the entire array from people who are coming in for cardiac, respiratory, neurologic, or diabetic problems, and many more. And they're all hoping for a cure. They're all hoping to get better. I mean, we naturally think a hospital is not a place to live, right? You go there, you get fixed, and you leave. It's like bringing your car to the garage, right? You hope that the problem shows up and you can figure out what's wrong and get out. So I must say that in the course of our jobs, we see people and their families going through every transition, from thinking that someone with COPD, very common respiratory problem, is going to, basically live to be 90, starting at age 60 with it, to realizing that, well, it may not last as long with this. Every visit to the hospital may not come out with the same level of recovery. And we do have to be present, the nurses mostly, for some of the lengthier conversations and the lengthier transitions. People don't go through these, it's not always an epiphany, like, suddenly, there is an end to this beautiful existence. But it comes very slowly, and you wind up working with people who go back and forth. And I'm sorry, what's your name? Susie. So we relate very much to being in that situation where the patient has one desire, the family has one desire, or if they're different, they could be the same. They're all evolving together. I mean, that's what we do in our families.
Use your extreme case.
Right. Well, yes and no.
Maybe
I mean,
not.
I don't think
What we see.
it doesn't seem that extreme, and I'll tell you what it's about. Just from to focus a tiny bit on that case, there was a beautiful comment here that said, well, he may not have the choice, right, about Medicare criteria and life and death, right? I mean, there's 2 separate categories here, because if you're wealthy and you can afford to do whatever you want, you can get, the finest care, and you don't have to deal with Medicare, and you don't have to deal with paying for it. But to address the wealthy, issue there. But we're mostly dealing in a world with limited resources. So the choice that didn't get focused on immediately was the fact that the MD has to assess the prognosis of 6 months or less. So if somebody comes to him and he looks as good as he thinks he is, and he looks like he's got 2 years left, he can't get hospice, no matter what his pulmonologist said. You can always do an inquiry and have an assessment there.
You're saying he cannot?
Not by Medicare.
Right, okay.
Not with a Medicare benefit, right? Which is, what we're all
And most
referring to here.
insurances follow Medicare too. I know sometimes people are younger than Medicare age who we see. So you can pretty much guarantee that any of the private insurances or Medicaid would follow suit. Before we move back to Dr. Anderson, I just want to mention Dave works 7 p.m. to 7 a.m. in the hospital. We're not there. I mean, we're all on call, but Dave is physically the palliative team member who's in the hospital all night long. So that's a very important role, because you don't have us all, we can't be paged at 2 a.m. and say, can you come over to room 412, So Dave's role is a really important role, I feel, for our palliative team. And also, he's a great mentor to some of our younger nurses. We have a lot of RNs right now who are very interested in palliative care, and several are actually working toward a credential in palliative care, even though they don't have any intention to leave and go work for hospice. They want to be hospital nurses, but they want to know more and feel better about what they do and have more skills. And they're actually going through a process right now where they'll take a test in the summer, and hopefully they will have this added credential. Dave, while being there for patients and families through the night, it also serves as quite a mentor for a lot of the nurses. No, it's true. That's why we call him a champion.
He's a champion.
He's a nurse champion.
Dr. Anderson, what do you...
Speaking of nurses,
Oh.
I have a question. So if you're getting hospice care at home, where do those nurses come from who come and change dressings and do all that? Is that from the hospital?
They come from hospital.
No, not from the hospital. They come from hospice.
So hospice nurses-
Hospice actually employs, how many nurses? 8, 9?
Well, I think we have 6 primary nurses there.
Okay, 6 full-time primary nurses who
They each have a caseload of about 12 patients, sometimes more.
and they basically make regular visits. You know, they just drive around and do home visits.
So Dave, are you the only palliative nurse
Well, let's clarify a little bit. You know, I am on this team, but I'm not, strictly speaking, a palliative care nurse. See, I work for the hospital, I work in acute care, and we see the entire array of patients, those who are in and out, and those who are in and we're wondering how they're going to get out. So, yeah, that's a little different than the nurses that they're talking about who would come do the home visits.
Yeah. So some of it, so for instance, Tim, Dave, and I are hospital employees. Dr. Anderson and Jane are Hospicare employees, but the hospital contracts for their time. So yet again, I see that though as another example of working as a team, only in a broader way. Because many communities have similar models where the inpatient palliative team might have some people who are actually hospice employees in the local hospice area. So we have our team in the hospital, we have the team of the patient and their loved ones, and we have a team with the hospital linking with partners in the community.
Thank you.
I have a question. We have here a care team, it's called, just people who visit those who have a need, going through a loss or an illness. They might not qualify for hospice, but could use palliative care, but are home, not in the hospital. So can people be referred, and how does that happen to palliative care? How would they be referred, or can they be?
Yeah, we as outpatients, patients have basically two options. Some patients get referred to hospice it doesn't have to be by a doctor. It could be by a neighbor. It can be by their mother or their child. And once they get a hospice referral, then we contact their doctor, find out if they want us to see the patient, and as long as their doctor's okay with that, we have a nurse who does an assessment at home, and then we confer over whether that person's actually appropriate for hospice care, and if so, we sign them on. So that can happen on an entirely outpatient basis without even going to the hospital. The other thing that we have, and we're hoping to have a more extensive home palliative care program. We're just sort of trying to launch it now. We have this thing called PATH. I can't remember what PATH is.
Personal attention to health.
Personal attention to health, which is sort of a nascent palliative program where people who have serious health needs or social needs or psychological or spiritual needs get referred to us, and then we have, again, a visit at home. It's usually a one-time consultative visit where the social worker and or nurse will decide what services that person really needs, and then helps link them up with what's available in the community.
That would be really useful to us. So how would that referral happen?
For that, you could just call Hospicare directly.
Oh, still, it's through
Yeah,
Hospicare.
yeah, that doesn't need a physician order. That's just, you have someone, again, with some complexities that need somebody to come talk with them. Yeah.
And you know, our social workers know all of the resources in the community, you know, the Office of the Aging, where to get help with food, you know, supply, all that kind of thing. So.
Oh God, you guys just answered my big. I had a sign against my will to like fill up. I found my resources.
So the other thing is, if there are medical issues, they can have an outpatient consult by either Dr. Anderson or myself. And so what we do in a consultation, whether it's outpatient or inpatient, we do need a physician's order to do it. So again, it can come, the idea can come from anywhere, and you can call hospice, and then Hospicare will try to get the order from the physician. But so if we're visiting somebody at home, we make an appointment with them, so that, you know, it's a time that works for everybody. Sometimes they want their kids there, or you know, we go to the home. Usually we spend about an hour, and we basically listen. You know, we say, what are your concerns? You know, what are your health concerns? What are your practical concerns, and often for a home consult, it's somebody who is either aging and looking at, their healthcare decisions, and they want help with, like, completing a MOLST form, which I think you may have heard about, medical orders for life-sustaining treatment, or they may have a physical issue. They may have, like, one thing is often we'll get somebody who's caring for their elderly and demented parent in the home, and it's getting harder for them to cope, and they're trying to figure out what should they do next. Mm-hmm. And sometimes we can help with symptom management that makes life a little easier, and sometimes we're just talking about, well, have you thought about a nursing home, and kind of talking them through that kind of thing, or connecting them again with PATH or other services. Sometimes it's, I've had a few patients at home, elderly people with pain, and their primary care physician just didn't feel really comfortable with how to manage it. And it is really helpful to go into somebody's home and see what the situation is. Mm-hmm. You get so much information that you don't get in an office visit just by walking in. And so again, it's really more of a holistic thing, like, are you taking care of yourself in addition to taking care of your mother? Are you, we talk about a lot of different things. In the hospital, it's a little different because usually it's related to some acute situation. That's why they're in the hospital. And this hospital, they usually actually use us for end-of-life care. So it's not as rich of a palliative program as we would like. But so they ask us to come in and have those difficult conversations about, we're running out of options for treatment, for curative treatment, and so these are the other things to consider. And usually, like, when I do a consult, I almost always ask, what's the most important thing to you right now? Because especially in the acute situation, people tend to be caught up in the momentum of fix, 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 fix. We're going to do the next thing and the next thing, and yeah, we want to go to the ICU, and yes, we want intubation, and they haven't really thought about, the consequences of those decisions beyond, I'm trying to survive. Mm-hmm. And so sometimes we can kind of slow it down a little and say, well, just remember, you want to think about what's going to happen after this, after this intervention. And this is this is what we expect after this kind of intervention, and are you okay with this array of possibilities? You might survive, but you might be, brain damaged and unable to talk, interact, so do you want CPR? So we have those kinds of conversations, and we also tend to ask people much more in depth. If they do have pain, we do a really thorough pain assessment. Where do you feel it? What does it feel like? When does it start? When does it stop? And because I think palliative, part of the reason palliative care kind of grew out of the hospice movement is because in hospice, that is our treatment plan, comfort. So we get much more in depth in terms of what are the symptoms you're feeling and what's the best way we can alleviate those symptoms. So we became the medical experts in symptom management. So we just know how to think about these things a little bit differently than the typical provider whose top concern is not your pain. Their top concern is, how are we going to save your kidneys? So, yeah.
Maybe I'm taking Liz's question from her, but piggyback and change my question if you think's wrong. Last session we did 5 wishes in which people lay out, even as young as we are, lay out what your wishes are for end of life.
Yeah.
And I'm wondering, how do you get access to that? And do you re-interview and redo some of those questions about end-of-life care? I also have a piggyback question. In the New York Times this week, there was an article about a physician whose father, during his during his productive life, had hesitated to give end-of-life antibiotics because antibiotics oftentimes don't really do much to preserve someone's life. They preserve it, but in the end, it's not really helpful. So he had hesitated to do that. And when he got Parkinson's and went into nursing care, he changed on his end-of-life care. He said he wanted to be resuscitated and all possible measures. So his son, who also was a physician, was faced with his whole life was don't give antibiotics, and yet on the form it said all possible measures. How would you handle a case like that?
I think
So there's two questions.
the first thing you need to do, and we work with this issue every day, is determine if someone has the mental capacity to still make decisions for themselves regarding their health care. So yes, advanced directives and what someone comes to us with or what they don't have, or any inkling that things have changed in some regard, is something that we look at with pretty much every single patient situation that we're involved with. But that issue of capacity is really important. Many times I'll have, and again, as a social worker, a lot of times I work often more with families and loved ones than the actual identified patient, because that's just what I do, and I know that whole system really is key here. Oftentimes we'll get someone who says, I'm the healthcare proxy, I'm the power of attorney, don't listen to what mom says, I'm it. When maybe mom has had very clear conversations with us about what she wants or doesn't want, or whatever. So we first have to make sure that it's clear, or that all involved are clear, that someone has the capacity to do that or not. Capacity is different than legal competency. Those are two different things, and people throw around the words and use them interchangeably.
Could you elaborate on that?
But they're very different. And maybe you heard about that when Chuck Gutman was here. I don't know if he got into that at all. But what we are concerned about is, does this person have the mental capacity to make decisions regarding his or her health? And physicians can do that. If it's a really sticky situation, we might ask a psychiatrist to come and consult in the situation to make more of a hard decision about that. But that's an issue I deal with a lot. I honor so deeply the care and the concern that family members and loved ones have for that person. But bottom line, who's driving the bus here? Are you still driving your bus, or are your kids driving the bus? Who's in charge here? And it's really important, and we do talk about decisions like that all the time.
Yeah, and I really think it's really important that people have those conversations before they get sick. I can't stress enough what a relief it is to actually be faced with somebody who is unconscious or seriously ill, and everybody in the family knows what that person would or would not want. And they'll say, my father would never want to be on a ventilator. That's not how we envisioned his passing. And if it's a difficult conversation to have, because frankly, death is a dirty word in our society. No one wants to think about death. And it's a universal experience. We're all going to die, every single one of us. And yet, it's something that nobody wants to talk about. And people really do have a magical sort of idea that maybe I'll be the person who doesn't die. And, well, Susie, like your brother, he's probably thinking, I don't have to die, But in fact, we do have to. And I think that there's been an evolution in this country in medical care recently that acknowledges that we can't continue to think of death as this enemy that we can put off forever. And in fact, it isn't good to do that. It makes people's lives miserable. The fact that most of our Medicare dollars are spent on the last few months of life, when people are basically in the hospital and having a pretty miserable existence, instead of, when they're younger and able to benefit from the care more and then have a comfortable death. If we could face the fact that people are going to die, we wouldn't, be doing these incredibly desperate, futile attempts at the end of life to keep people alive when their body is just failing. So I think that having that conversation, picking a healthcare proxy for yourself who is someone who really knows what you would want, is a really important thing to do. And even in young people, I think it's a good idea to start having those conversations.
Liz, I think
And
you had.
well, I wanted to address this situation a little bit. We frequently have situations that are similar to that, where somebody is saying that they want something that we actually think they don't really want. That they say they want resuscitation is a very, very common, but they don't want certain other things, or we know that they're not going to benefit from resuscitation, and it just, we just don't want to put them through that. And so what we try to do is have the conversation from different angles and try to tease it out a little bit and help them see that what they really want isn't what they think they want. I had a patient this week who nearly died in the ICU, and said very clearly after that, he agreed to a DNR, he agreed to not be intubated, he had his internal defibrillator turned off, but he said, I never want to go through that again. So we said, okay, so the next time this happens, we're not going to bring you back to the ICU, right? Oh, well, right, except bring me back until my family arrives. And I had this conversation with him 5 times, okay, on 5 different occasions, same conversation.
So did I.
Yes.
With all the family who showed up from out of town.
And I had to kind of really go over it with him. Well, this is what we would do instead. We would keep you upstairs on the medical floor. We would give you morphine and Ativan to control the shortness of breath and the chest pain, and we would keep you comfortable, and you would probably live long enough till your family got here. And P.S., there's no guarantee if you were in the ICU that you'd live any longer, until your family got here. And he finally agreed not to go back to the ICU, but I made sure that his physician knew, don't bring it up again. Because he just, it was clear what he wanted, and he didn't understand.
But in that case, too, in talking with him individually and also with his family, he was terrified of dying alone. Mm-hmm. And much of this, finally, I teased out of him that was really at the root of so much of this, is he didn't want to die alone. He didn't want to go home because he was afraid he'd be alone at home when it happened. He didn't want to, he really didn't want to leave the hospital because he knew, well, at least if I die, I won't be alone. So it took some time to really, and that's the beauty of the counseling process, is to try to, really work with someone to find out and help them come to some insight about what's at the root of it.
And sometimes, in addition to sort of helping them define what's important to them, we need to educate people about what's possible and what isn't possible. And I really think that the media has portrayed the possibilities of medical care way beyond what's really true. Everybody, you see these episodes of, Dr. Kildare or whatever, where people come into the emergency room flatlining, and 15 minutes later they've had their CPR and they're eating lunch with their family. And it's, really less than 10% of the time is a resuscitation even successful in actually restoring a heartbeat. And when it does, there's often a lot of attendant brain damage and other broken bones. A lot of injury that goes along with the whole process, which people don't realize because that isn't really the way it's portrayed.
It's not good TV.
Listen, you've had a question for some time.
Yeah, first of all, I'm just so happy to hear that you think as a team family systems, because those people who are not wanting to let go of their parents is they're not dealing with their own grief about that. Mm-hmm. So that can make the death even harder for the person. Mm-hmm. But Jane said something earlier that evoked something in me that I wanted to have addressed. I worked as a volunteer in hospice for quite a few years and saw people come in and enjoy this beautiful, caretaking, loving, spiritual environment. And sometimes they had to be kicked out because they got better, because they've never been loved and cared for that much, was my belief about it.
Yeah.
On the other hand, I also saw people that the doctors wouldn't release from their care until 2 days or a week before they died, and they never got to experience hospice as it's meant. And I have never been able to understand why doctors do that. Do you have any?
Yeah, I can tell you
As a
exactly why.
doctor.
I can tell you exactly why.
My theory is it's money, but that's
No,
so
no,
awful.
no, it's not money. It's not money.
It's not money.
No, it's not money. It's because doctors are human beings, and they're afraid of death too, and they feel responsible for the person's life, and they feel responsible for keeping the person alive. And the way that we were trained, I was in medical school in the 1970s. Death was the enemy, and if your patient died, it was because you failed. That was really the way that we were taught then. I understand it's being taught completely differently now, but that's how it is. And if you poll doctors who have patients with serious illness, and you ask them how long they think that person has to live, they will consistently overestimate how long that person is going to live, especially if they know the person and like them. If they've been their doctor for like 20 years, they're not willing to look at the person's death either, But you're absolutely right that it's a big problem for us when we're called when a person is literally in extremis, We go to the house, and this happens a lot. Our admissions nurse goes to the house, and she calls me and she says, this person is about to die. They're already modeling. They can't breathe. All I can do is give them morphine and make their breathing comfortable.
6 months of care.
And the person had cancer that was metastasized and had stopped treatment because there was no options for treatment left, and yet the person was not referred to hospice because even the doctors kind of this is why we like to get referrals even from family members and neighbors who can see the situation a little bit more clearly.
So what can we do to get these doctors retrained?
Yeah, well,
I would say start the conversation with your own doctor.
Yes.
True.
Yeah.
If you show the courage and the initiative to open this discussion, it's like an opening door. And so that's really important. You can teach your doctor how to be a doctor.
We are seeing an increase, just to boost the doctor's side. Within the hospital, in the month of March, we had 52 palliative consults in the hospital, and our norm is like 36 a month. So we're seeing the doctors more and more today refer more to us. I think they trust us as a team. They trust our abilities. Sitting here, we probably have 140 years experience, we're seasoned people. We've been around the block a while, and I think the physicians are trusting us more, and new physicians, as you mentioned. We have a lot of hospitalists that are quite young. This might be one of their first jobs as a full physician, and they come from programs where palliative care was just a given. So we're seeing more and more people more and more physicians and providers coming around and realizing that it's a good thing. And I don't know how we shift the thoughts of, what you were trained is to just keep everybody alive at all costs.
Yeah, I think that basically through experience, we learn through experience. I think that's how human beings learn. And people in the community have learned that hospice is a good thing because they've had relatives or friends who have died in hospice, and they understand that that person had a great passage from this world because of it, and that's why hospice is so popular here in Tompkins County. If you go to Cortland County, they don't have that perception of hospice yet. We just picked it up, so it will be soon, I hope. And there's a lot of fear around death still, and around hospice even. So it's basically through learning by seeing that it's a good experience. And I think as doctors see that their patients have a great end of life with us, they will be more likely to refer. That's what I'm counting on, sort of, and word of mouth.
So I'm counting on everybody going to have a conversation with your doctor.
In doctors' defense, too, I think it's actually probably a lot more difficult for them to see the changes in their patient who they see on a regular basis. If you think about, kids, your own kids, watching your own kids grow up, and then you watch somebody else's kids grow up, and it's like, wow, they've really changed in the last 2 months. You know, like since the last time I saw them 6 months ago, they're really different. But you don't see those changes in that dramatic way with your own kids. And like when I walk into a room seeing a patient for the first time, I get a good sense of prognosis just that first time. But that's because I don't have that whole history with them. I haven't watched them slowly lose weight. You know, I haven't watched them slowly become debilitated. And I don't have that investment of knowing them and of course hoping that they're going to live as long and happily as possible. So, you know, I don't think it's a human. It's just
Yeah, it's an adjustment. I mean, there are lots of stories of physicians who have patients who are suffering from liver failure, and the person's getting really jaundiced, and the doctor doesn't see it because they're seeing the person every week, and the change is so mild from one week to the next, and they don't notice it. And then another colleague sees that patient and says, "Oh my gosh, look at that jaundice," and their own doctor didn't even notice because of the gradual change. It's that same sort of thing.
I would also can I say one thing and then we'll go? I would say technology is a concern too.
Huge concern.
There were times, decades past, when we couldn't do things. Life won, right? And now there's so many things we can do that it takes so much more wisdom to know how to use the tools that we have. And so we need elders, right? As Dr. Campbell was talking about, we need elders in our midst. And so I think part of it's about us being wise in the community and offering that wisdom as elders to know how best to use the tools that we've been given. Yeah.
First, I want to thank Bob and Fred who convene us and the Unitarians, because I said the last time we had this, it's so good of all of you to be present to us in a forum that's not only friendly, but we can de-escalate the fear. And we can raise up whatever faith, as Pastor said. I don't remember your name.
Tim.
And you said before, in confronting some of these difficult, as a caregiver, and I want to focus on caregiving, you said sometimes you feel like you're getting burnt out. And you gave me a little inspiration that we have to have longer wicks and shorter fuses. I mean, rather than shorter fuses. I served for 1 year at the Washington Hospital Center with the sick and dying in the kidney dialysis unit in getting my MDiv, my Master of Divinity for Catholic U. And that was after being in Senegal, West Africa, as a Peace Corps volunteer. It was said by the panel that you're bringing it back to medicine. No, I would defer. You're being the bridge right now, but you're bringing it back to humanity. You're bringing it back to home. And just like this room is white, that's how most of our hospitals are, cold and sterile and undoing. And I've been to a hospice in Akron, Ohio, that was just like someone's home. And the mother had called me out because I had taken care of her son here in New York. And the point I wanted to get on caregiving is that my own beloved, we got hospice for him when he was told, he died 7 years after he told he had 3 months to live. He had PML, which most people with the lesions on the brain, 3 months you're out. But I prayed for him and came back from Rwanda, and he was up and about. But the point I want to make, with him, the hospice then sent me afterwards materials I still have in my files on loneliness, on anger, on separation. And you're already dealing with that around this room. And then, so that's the first question I have. And the second point is, about aftercare to the loved ones.
I should have mentioned that part of this Medicare hospice benefit includes bereavement support.
Exactly. And then the other thing is, one of my most beautiful experiences, I mean, I've done everything from digging a woman's grave, closing a man's eyes, but then bringing that home and washing my father's body before we sent him to the funeral home, washing my friend's body, washing a body of a man who I had to bring to hospital. He died of pneumonia in a building with no heat and hot water, but we had to bury him in Jersey because we couldn't get him back to Ivory Coast. But the most beautiful one, in one sense, was my neighbor, childhood neighbor. His son called me, says, "Michael, Vincent, don't go to the nursing home. My father decided no more care." so we're going to put him into a nursing home. And I said, no. Dick told me, his father. I said, your father told me, and I told your father, that when he was ready not to have any more care, that I would take care of him at home. And I went, and by the Spirit, I don't care what anyone thinks, it was by the Holy Spirit, I stayed up for 5 days, didn't go to sleep at all. He had his sister come in from New Jersey to Staten Island. He had an assemblyman who died sooner, right after him, that we thought would live forever, so tomorrow's not promised to anybody. And it was a beautiful experience. And so sometimes it's not only the pastoral care after the fact or during the fact, is I think all of us around the room have to realize we'd be all cadavers if we didn't have whatever spirit we do hold within this corpse or core. And that has to be taken care of too. So the caregiving, how do you take care of us, caregivers, after the fact of dying?
Well, as Dr. Anderson said, there is a benefit through hospice, and even people, at least in our community, which is another reason why we have an amazing hospice here, they will open their bereavement groups to anyone, even if you didn't officially have a patient receiving hospice services. There's one-to-one care. There is a lot of material that's available. I know from the hospital perspective, I get calls all the time long after people have left, either discharged home or have died in the hospital or whatever. There's a lot of help available. I might refer someone to private therapy in town. We have a lot of great therapists here who are very, very skilled in loss and sort of transitions like this. So we're still involved, but the active bereavement piece of the benefit is definitely there too.
And thank you for all your efforts.
Thank you. Thank you. Yes.
Hi. I'm really glad to know you have all the bereavement and follow-up stuff too. That's great. Speaking of bridges, I was curious whether you have any liaison or work together at all with the ACT team. We have a mentally ill daughter currently living at home, and the ACT team is short for Assertive Community Treatment, one of these cool acronyms. And they provide what sort of in-home kind of treating symptoms, keeping in touch, making sure that they're okay, and it's coordinating with the family, assuming they are living with the family, which isn't maybe that often. But I just recommend them highly. They're really effective, and I just don't know if they could probably learn a lot from you. And I don't know how many elderly folks you have that also have mental issues, but it's just something to sometimes I think they could do a little more of the kind of spiritual, emotional, whole kind of thing. But everybody does what they can, and it's amazing.
We'd be happy to connect with them, and we do connect with a lot of our partners in the community. Just wanted to mention that even though we're talking about elderhood, and I understand anyone 55 and older is a near elder now, like that's we can get into senior housing, we do see a lot of people who are, unfortunately people also have serious illness at different ages of the lifespan. So we do see people, and I'm thinking in particular, maybe people that were very active in with mental health needs, maybe in and out of institutions, might also get some kind of illness that's life-threatening to them too. So we do have situations where we're working with someone who is, or possibly has a lengthy psych history plus now dementia, toward the older years, or a psych history in addition to liver cancer or something.
Well, the way our daughter's going with her lifestyle, she may predecease us. It's kind of like Suzanne's brother.
Well, connect with us, and before I forget, we did leave some information, both the palliative care brochure from the hospital and the Hospicare brochure on the table. Jane and I each have our cards over there. There's some other interesting information there. One thing we're doing a lot of is we're linking with Cornell, both Weill Cornell Medical Center and our local Cornell, on different projects regarding palliative care. We've been, and also with Ithaca College, we've got a lot going on both within the walls of the hospital, within the walls of the community, and then elsewhere too. And we're kind of seen as, the way I see it is all the New York City area teaching hospitals see us as this little gem of a rural counterpart to all that they're studying in urban areas. So we're very involved in a lot of different ways. Yes.
Thank you all for being here today. So you talked a little bit about how you have these difficult conversations with patients or their families, but do you have any advice for those of us who would like to start the conversation with people who don't want to talk about it?
It's very hard. There's
good question.
Yeah. The organization, yeah, that's one thing you can do. We actually have videos too. There are videos about end of life and about MOLST and that sort of thing.
There's a website called compassionandsupport.org, I believe. And there's a physician, Dr. Pat Bamba, who, again, you might have heard about her because she was integral in creating this, the MOLST form, the medical orders form. But that website does have sections for both providers or just people, and you can certainly link into there. I think my first thought would be own it yourself and say, honey, or mom, or whoever it might be, I'm really curious and wondering what to do for you should X, Y, or Z happen. Or I would like to have a conversation with you now about some things I've been thinking about. Rather than saying, you need to tell me what to do, or you need to tell me what you're thinking, or you need to think about where you want to be, that kind of thing. Just like turn it around and just own it. And sometimes that helps. I know it is frustrating. Sometimes the neutral third party idea that some have mentioned really helps, and that's why we're here. Is we care, we all are very passionate about this work that we do, but we aren't related to your loved one, so we sometimes can help in that regard. But I think starting by just owning it yourself, because it is hard if it's a big mystery, and if I have a mom who is elderly and didn't really ever want to talk about any of this until my dad was dying. Now I'm very clear, and she's very clear what she wants because we've gone through it already. But otherwise, I don't think she ever would have talked about any of this,
Well, I was actually thinking about the reverse, where I want to talk with children or young people
I
about,
see. Oh, and they,
and they
right,
don't
I
want,
yeah. Because they don't want, they can't imagine mom dying. They can't imagine life without mom.
There's a new thing happening. I think it was last year. It was in August. National movement. Let's have dinner and talk about death.
Oh.
Yes. So it's a particular day. I think it was in August. So that's kind of a way to take the pressure off and say, oh, I'm just doing this thing because it's people are doing it, and so There's also there have been some events in Ithaca. There's a Death Cafe movement, which is you can look that up online as well. But there's some people locally who have been doing death cafes at the Quaker Meeting House, it's a similar kind of very informal setting for people to just have an opportunity to talk about whatever their feelings and thoughts are about death and dying. And that one of the few requirements of a death cafe is that you have to serve food. So if you're thinking about doing it just with your own family or friends, you could just make it a little bit of a light social event, and people are usually actually looking for an opportunity to have permission to talk.
And you could say no birthday gifts until we talk about this.
Yeah, you're really doing them a favor, because if you can sort of get them desensitized to the idea of your dying now, it'll be so much easier when you actually are terminally ill. those children who can't even have the conversation now because it brings them to tears just to even imagine it, well, when they actually encounter the reality, it's going to be so much more difficult. Whereas just making them think about it now while you're vibrant and healthy and you look great, that's doing them a favor, and it will normalize the experience. You know, if you present it to them as a part of life, they may be able to come around too.
I went to this great discussion at church Sunday, and the panel said, "This is our homework. We need to go talk to them." You could just blame it on us.
Yeah, okay. Well, I mean, thinking about choosing a healthcare proxy, I mean, you know, it's really like critical in my mind that, you know.
And you know, to be realistic, we encounter a lot of people who do not make their children their health proxies.
Yeah,
because they say, I know that my child would just never be able to make the tough decision to stop life support or whatever. And they pick someone else who they feel understands their values and their goals and would be really a better spokesperson for them.
I think we have another question over here. Are there any other?
Mine's pretty quick. In my lab, I tend to refer people to adult protective reasons. Do adult protective workers tend to refer to
Can't hear you, Sue.
Can't hear you, Sue.
She said she wondered about whether adult protective workers ever refer people to us. Well, again, in my social work hat, we use adult protective a lot. Not so much in my role anymore, but when I was a house social worker, we do use their services a lot. I wouldn't say they necessarily do. I mean, their focus is much more on the safety, getting more help into the home, maybe some financial abuse going on or that kind of thing. So we don't necessarily receive referrals from them.
But we could.
But we can. You know, visiting nurse service is another area where they're in the homes, just like adult protective is, where they kind of see what's going on and might have some concerns. But we would certainly welcome any calls, any
Well, I
suggestions.
just wondered if I just went to, or would it be better for me to, if I think it should be hospice, I should
Go straight to hospice.
Go straight to hospice.
And give them a call. Yeah.
I want to say just what a wonderful combination of expertise and wisdom, and we genuinely appreciate your coming and great presentation.